this basic radiology course in order to help the residents in the emergency rooms to pick up the cases and to diagnose the accurate pathology seen in the CT scans. First, we should know if the patient is requiring some of the preparation before the scanning or not. And actually, there is no special type of preparation apart from the fasting from 4 to 6 hours if the patient is going to be injected by contrast material or to receive anesthesia. And these are the causes for injecting the patient with contrast material. And mainly, we injected the patient whenever we are looking for or suspecting inflammatory or neoplastic pathology. But we do not usually need the injection of contrast material in cases of emergencies and the cerebrovascular stroke, as well as in traumatic cases. The patient comes to the CT machine and is lying supine, as you can see, and we started the examination by the scanogram. In the scanogram, it's just a plain X-ray for the area to be examined. The value of this scanogram is to locate the area to be examined. And here, we obtain the scanogram in the lateral view and start scanning from the skull base parallel to the orbitomeatal line, which is a line joining the middle part of the orbit and the external canal. Passing from the skull base until we reach the vertex, the scan will ask about the interval of scanning. Then we scan this area in adults every 1 centimeter, and in the pediatric age group, we scan this area every 7 millimeters. After finishing the scan, you should have these sections in on the X-ray film, starting from the lower sections in the skull base and ending by the vertex of the skull. Then, in order to know the anatomy, you should know that we have 4 ventricles in the brain, the fourth one, the third, and 2 lateral ventricles. And we use this ventricular system to know the anatomy. Starting by the fourth ventricle, which is present in the posterior fossa. And you know from this image obtained by MRI, you know that anterior to the fourth ventricle is the brainstem and posterior to the fourth ventricle is the cerebellum. Then if you look here, this is the fourth ventricle and this is the brainstem anterior to it, and this is the cerebellum posterior to it. You know that the cerebellum is composed of left hemisphere, right hemisphere, and cerebellar body, which is known as the vermis of the cerebellum. And you can see that the fourth ventricle is big in the middle and small above and small below. When the fourth ventricle is big, the biggest part of the brainstem is in front of it, and this is the bones. When the fourth ventricle is big, the bones is in front of it. When the fourth ventricle is small from below, then the medulla oblongata is opposite the fourth ventricle. When the fourth ventricle is small above, then the midbrain will be in front of the fourth ventricle. Look at this sections, and here you can see the fourth ventricle is big. Then this is the bones, and the small artery anterior to the bones will represent the famous artery, which is the basilar artery. And if you go inferiorly, the fourth ventricle will be small. Then anterior to the fourth ventricle, whenever it is small, you are dealing with the medulla oblongata. And here you can see the left cerebellum and the right cerebellum. Above you can see the cerebellar vermis, and below you don't see the body of the cerebellum. You see a space filled with CSF inferior to the vermis of the cerebellum, which is known as the valliculum. Then if you go up, you will see that the fourth ventricle will become also smaller. And in this area, you will see a very important structure, which is known as the quadrigeminal cistern. And this quadrigeminal cistern bordering the midbrain from its posterior aspect. And here you can see by this MR image, you can see the quadrigeminal cistern, you can see the typical configuration of the midbrain. Then whenever you look to the fourth ventricle in the posterior fossa, if the fourth ventricle is large, then you are dealing with the bones anteriorly and the basilar artery anterior to the bones. If the ventricle is small from below, then you are dealing with the medulla oblongata anterior to the fourth ventricle. If it is small from above, then you are dealing with the midbrain, and you can see also the quadrigeminal cistern. Then, in order to know the anatomy of this, you should look for the ventricles. Here we are cutting in the lateral ventricles, especially in the frontal horn and in the occipital horn, passing by the third ventricle. This is the frontal horn of the lateral ventricle, and this is the occipital horn, and here you can see the third ventricle. In this area, you know that you are dealing with the basal ganglia. The basal ganglia are 4: the caudate, the lentiform, the thalamus, and the dentate nuclei. The dentate nuclei are present in the cerebellum, and the rest of the basal ganglia are seen in this section. Here you can see the region of the caudate nucleus, and in this area you see the lentiform nucleus, and on both sides of the third ventricle you can see the thalamus. And these structures are clearly visualized in the MR image. You can see this is the caudate, and this is the lentiform, and this is the thalamus. Then you will see a very important structure passing between these anatomic structures, which is the internal capsule. The internal capsule is passing between the caudate, the lentiform, and the thalamus, and this is the internal capsule in the MR imaging, passing between the caudate nucleus, the lentiform nucleus, and the thalamus. Then if you look to this section, and you can see this is the frontal horn, and this is the occipital horn, and this is the third ventricle. Then you know very much now that this structure will represent the caudate nucleus, and this area will represent the lentiform nucleus. And here you can see the region of the thalamus, and this is of course the internal capsule passing between the caudate nucleus, the lentiform nucleus, and the thalamus. Then if you have this section in the brain, you should see 3 calcific shadows, and these are normal in any adult brain. The midline calcified shadow belongs to the pineal body, and the two calcified shadows represent the calcification in the choroid plexus in the posterior horn of the ventricle. These foci of calcium are normally seen in any adult brain. And this is the pineal body, and this is the choroid plexus on the left and the choroid plexus on the right. This is the frontal horn, this is the third ventricle, and this is the occipital horn. Here you can see the caudate nucleus, this is the lentiform, and this is the thalamus. Then after going up, you will see the body of the ventricle. You are cutting here through the body of the ventricle, and you see this is the body of the ventricle on the left side, and this is the body on the right side. And you see the left cerebral hemisphere, the right cerebral hemisphere separated by the falx cerebri. Then going more up, you will not see the ventricles, but you see the cerebral hemisphere on the left and on the right, and you can easily identify the difference between the white matter and the gray matter. The gray matter represents the cortex of the brain, and the white matter represents the medulla, let us say, or the central part of the brain. And this is the MR images of the brain in the T1 and T2 weighted images. I will explain this in the next talk. And you can see the white matter and the cortex of the brain as well. Then if you see a lesion and you would like to locate this lesion in a certain part of the brain, if I asked you about here, you will say left cerebellar hemisphere, and here you will say the vermis, and here you will see the bones, and here you can see the frontal lobe, and in this area you will see the temporal lobe. Then if you are cutting in the ventricular system, you can draw 2 lines like this, an anterior one and a posterior one. Then the part anterior to the first line will represent the frontal lobe, and the part posterior to the second line will represent the occipital lobe. Then what about the middle portion of the brain? It either represents the temporal lobe whenever you are cutting inferiorly, and the parietal lobe wherever you are cutting superiorly. In order to know the inferior from the superior, look to the third ventricle. The third ventricle is inferior. Then you know you are cutting in the temporal lobe, and this is the temporal area. But if you see the body of the ventricle, you are cutting in the parietal lobe, and this is the parietal lobe, frontal, parietal, and occipital. Then what happens if you are cutting in sections above the ventricles? You draw 3 lines, dividing the section into 4 quarters. The first one will belong to the frontal lobe, and there is no more occipital lobe. The occipital lobe is very small, and it cannot reach this high level. And also the temporal lobe has finished inferiorly, and you are left with the parietal lobe. Then you have only 1/4 for the frontal lobe, and the rest of the section will belong to the parietal lobe. Then if you look to the brain tissue, and you see this is the normal brain, you can see the normal size of the ventricles, and you can see also the normal size of the cortical sulci. And here you can see the brain atrophic changes, in which the ventricles are dilated and the cortical sulci are dilated. And you can usually see this in all the population, and this is considered normal for age. The ventricles are dilated and the cortical sulci are dilated. And this is the full-blown picture of brain atrophic changes, or what we call involutional brain changes, in the form of dilatation of the ventricles and the prominence of the extraaxial and cortical sulci. Then we came to the assessment of the cerebrovascular lesions, and we'll concentrate only on the intracranial hemorrhage and the ischemic strokes. Before we start this, we should concentrate on some of the terms used in the reports of radiology. And these terms, you can read this frequently: hypodense lesion, hyperdense lesion, and isodense lesion. What do we mean by hypodense lesion? It is a lesion that is less dense compared to the normal brain parenchyma. And let us to say that this lesion is black compared to the normal tissue of the brain. And this is what we call hypodense lesion. Hyperdense lesion is a lesion that is more dense than the normal brain parenchyma, and it will appear bright, as you can see this. An isodense lesion is exactly similar to the brain. How can you know that there is an isodense lesion here? By its mass effect. Normally, you can see that the ventricle on the left and the ventricle on the right, and they are separated by the falx cerebri in the midline. Then if you see that the right ventricle is compressed and is shifted to the opposite side, then you should know that there should be a lesion here. But you do not see the lesion, then you consider it isodense lesion. And this is the basis for the diagnosis. Then, why the lesions will appear hypo or hyper or iso? This is based on what's known as the density or the attenuation value. The attenuation value is measured by the Hounsfield units, and the Hounsfield, of course, is the physician who started the CT machine in the late 70s. And you can see that the normal brain tissue will measure about 30 to 40 Hounsfield units. Then any structure which will measure below 30 will appear hypodense, and any structure will measure above 40 will appear hyperdense. And this applies for the CSF, which will appear black because the density is from 0 to 15. And also the fat will appear black in the orbit like this, and the air in the paranasal sinuses will appear black as well. Then intracranial cysts, because of the fluid content, will appear black. Infarction is a dead brain tissue will appear black, and the brain edema surrounding some of the tumors will appear also black in the CT scan. Then the two lesions which appear hyperdense in the CT scan are the recent blood density or the fresh hematoma and the intracranial calcification. And of course, in order to differentiate these two lesions from each other, you should concentrate only for the clinical data. Patient with intracranial hemorrhage is quite different from a patient with intracranial calcification. But if you measure the density using the CT pointer, you put your pointer here, then the density of the hemorrhage will never exceed 100, while the density of calcium will be above 200 Hounsfield units. Then if hemorrhage is going to be collected intracranially, where? What are the sites for intracranial hemorrhage? Then look at this drawing, which is representing the calvarial bones, and the blue line represents the dura, the red line represents the arachnoid, and the green line represents the baya mater adherent to the surface of the brain. If hemorrhage is going to be accumulated intracranially, it can occur between the calvarium and the dura, and this is what we call epidural hematoma or extradural hematoma. And hemorrhage may accumulate below the dura, and this is what we call the subdural hemorrhage, or below the arachnoid, and this is what we call the subarachnoid hemorrhage, or inside the brain parenchyma, and this is what we call intracerebral hematoma, or inside the ventricle, and this is what we call intraventricular hemorrhage. Then, how can you discriminate between these types of hemorrhage? We'll start first looking at the normal scan, and this is the normal brain showing the normal ventricles and the normal cortical sulci containing CSF. Then if you look to this brain and you see the cortical sulci are now containing hyperdense blood instead of CSF, then you know that this hemorrhage is circulating with the CSF, and you know that this is the subarachnoid hemorrhage. And subarachnoid hemorrhage is the hemorrhage circulating with the CSF, changing the color of the cortical sulci from black to white, considering that the fresh blood is hyperdense. Then if you see a hemorrhage which is adherent to the inner table of the skull and is extending parallel to the inner table of the skull, then you know that this hemorrhage is outside the brain parenchyma. And outside the brain parenchyma, you have only the epidural space and the subdural space. In order to discriminate these two spaces, you look easily for the inner border of the hematoma. If you see the inner border of the hematoma convex, then you know that this is epidural blood. But if you see the inner border of the hematoma concave, then you know that this is the subdural blood. Then this is a typical example of an epidural hematoma. In the frontal region, you see the blood is going adjacent to the calvareal bones, and it has a convex inner margin denoting epidural location. And this is the typical example of subdural hematoma. You see the blood going parallel to the calvarium, and the inner border of the hematoma is concave. Then you know that this is a subdural blood. Intracerebral hematoma may be the sequelae of trauma, and this is known as cerebral contusion. But if the hematoma is due to hypertension or diabetes, then it's known as non-traumatic intracerebral hematoma, like this one. And you know the intracerebral hematoma occurs very close to the ventricle. Then the ventricular wall is very thin, and the hematoma has the chance to extend inside the ventricle, like this one. And you see a big hematoma here extending in both lateral ventricles. This is intracerebral hematoma with intraventricular extension. And not every intracerebral hematoma will extend inside the ventricle, but some of the hematomas can extend inside the ventricle, as this one, and some of the hematomas do not extend inside the ventricle. But you should include in your report if the hematoma is extending inside the ventricle or not. And this is important for the clinicians. Then, if I asked you about the source of an intraventricular blood, you should say that the intracerebral hematoma may rupture inside the ventricle, resulting in intraventricular hemorrhage. And also the subarachnoid hemorrhage may circulate with the CSF entering the ventricle, then it will result into an intraventricular blood. Then there are two main sources for intraventricular hemorrhage, which are the intracerebral hematoma rupturing inside the ventricle and the subarachnoid hemorrhage circulating back into the ventricular system. And this is an example of subarachnoid bleeding, showing hyperdense lesion in the cortical sulci and in the sylvian fissure, and you can see the recent blood density within the third ventricle as well. Then this is the classic appearance of an epidural hematoma. The epidural hematoma is located in a very tight space, and it will produce severe symptoms to the patient. Then the patient will go quickly for the CT scan, and the hematoma will be evacuated. But the subdural hematoma is located in a very wide space. Then the subdural hematoma had the time to exist for some time. And you know that the fresh blood density is higher than that of the brain tissue, and by time the blood will lose its density, and over a certain time or a period of time, the blood will be black compared to the brain parenchyma. Then if you see a hematoma which is hyperdense compared to the brain, you know that this is acute hematoma. And if you see a hematoma which is black compared to the brain, then you know that this is the chronic hematoma. And if you see a hematoma which is almost similar to the brain parenchyma, then you know that this is the subacute hematoma. And this rule is not applied for the epidural hematoma, because the epidural hematoma is almost always acute because of its symptoms. But the subdural hematoma can be seen in the acute phase, in the subacute phase, as well as in the chronic phase. Then here you can see an hematoma which is almost similar to the brain. Then this is a subacute subdural hematoma, and this is a hematoma which is black compared to the brain. Then you are dealing with a chronic subdural hematoma. Then if you have a CT scan and you see a hematoma having the two components of the blood, the chronic one and the acute one, with a sedimentation level, then you know that this hematoma is not acute and not chronic. This is the subacute hematoma. Then whenever you see a hematoma having the two components of the blood, the chronic one and the acute one, you know that this is a subacute hematoma, not acute and not chronic in the same time. Then if you, a few words about the infarction. And infarction is an area of dead brain tissue, secondary to cutting of the blood supply. Then the infarction will appear hypodense. And you know that the infarction is not a specific lung lesion. It is clear enough that the infarction is not a specific lung lesion. Then why the infarction will compress the ventricle? Because of the edema around the infarction. Then if you see an infarction which is compressing the ventricle, you know that this infarction is surrounded by edema and it is acute. Then look at this. Here is an infarction which is compressing the ventricle, representing an acute infarction. And by time, the infarction will liquefy, and the liquefaction will result in loss of volume. And the ventricle adjacent to the infarction will dilate to compensate the loss of volume. Then whenever you see an infarction which causes dilatation of the adjacent ventricle, you know that this is a chronic infarction. And the infarction which is compressing the ventricle is known as acute infarction. What about the infarction which does not compress the ventricle nor dilate the ventricle? And this is the subacute one. Then if you see an infarction compressing the ventricle like this one, you know that this is acute infarction. And if you see an infarction which does not affect the ventricle, the left is almost similar to the right, then you know that this is a subacute infarction. And if you see an infarction which causes dilatation of the adjacent ventricle, then you know that this is a chronic infarction. Then you may read in the report this word, which is known as an area of encephalomalacia. An area of encephalomalacia represents an area of dead, liquefied brain tissue. And this is commonly seen after the infarction in the chronic state, but may be seen after trauma, may be seen after surgery, after hemorrhage, after irradiation, or after infection. Any of these insults can cause death of the brain tissue, liquefaction of the brain tissue, and resultant dilatation of the ipsilateral ventricle. But whenever you are asked what is the most common cause for encephalomalacia, it is the infarction or the chronic infarction. Then, sometimes the patient had a clinical evidence of a stroke, and you did a CT scan and discovered normal finding. And this is what we call infarction in evolution, and you should not wait. You should go for the MRI in order to discover the lesion, provided that you do not see any evidence of hemorrhage. And this is the follow-up by CT of the same case after some time, and you can discover the full-blown picture of the infarction. Then the infarction may not be seen in the early hours after its occurrence, because the dead brain tissue is not yet black to appear in the CT scan, but after some time you can see the evidence of infarction. And this is a series of follow-up of an infarction from the acute stage to the chronic stage with a vacuodilatation or dilatation of the adjacent ventricle secondary to a loss of volume. Then sometimes you will see an infarction with hemorrhage inside. And this infarction, we call it hemorrhagic infarction. There are two main causes for hemorrhagic infarction. The first one is venous occlusion. And after the vein is occluded, the arterial blood is coming normally, then the capillary blood pressure will be raised, and some of the capillaries will rupture, resulting in hemorrhagic infarction. The second cause is arterial embolism. And whenever the embolus occurs, then the dead brain tissue will appear in the CT scan. The body will try to recanalize this embolus, and a small hole is performed through this embolus, and a jet of blood will go through this hole and will rupture some of the capillaries, resulting in this hemorrhagic infarction. The diagnosis of hemorrhagic infarction is not important in itself, but it is very important in the underlying cause. Whenever you see a hemorrhagic infarction, you should look for the dural venous sinuses for thrombosis, or the cardiac condition of the patient for the source of emboli. Then whenever you see an infarction which is less than 1 centimeter in diameter, this is what we call the lacunar infarction. The lacunar infarction may be single or may be multiple. And whenever it is multiple, this condition is known as subcortical arteriosclerotic encephalopathy, which means you have too many lacunar infarctions. Also, lacunar infarctions may occur in multiplicity. Infarctions may be multiple. And you see, this is an acute infarction and this is the chronic infarction, and you can compare the density of both infarctions. Also, infarctions can occur in the same stage. These are bilateral acute infarctions, a larger one on the left side and a relatively smaller one on the right side. Then by the end of this talk, I'll show you some of the quiz cases. And what do you think of this case? Yes, chronic infarction on the right side and acute intracerebral hematoma on the right side, and this is true. You can know that both conditions can exist in the same case. What do you think of this? Subacute subdural hematoma, left or right? Bilateral. And you know that the bilateral incidence of bilaterality in the subdural hematoma is very high. And whenever you are in the exam, they usually show to you some of the hematomas, which is big on one side and very small on the opposite side. Then you will say this is the unilateral hematoma, and you will have only 50 degree of the degree, only 50%. Okay. Then what do you think of this case? Infarction, chronic or subacute? acute. And this is the usual way in the exam also. If there are 3 choices, they say to you the 2 choices which are not the answer, okay? Then you be aware of this. If this is an acute infarction, they say to you, is it a subacute or chronic? Then you will say one of 2, and you will lose the mark. Then what do you think of this structure? Calcified choroid plexus. And this? Third ventricle. And this? Left lentiform nucleus. And here? Right thalamus. Whenever you have right and left, you should specify if this is the left structure or right structure. Very important in the exam. What do you think of this? The pineal body. And this? Right coded nucleus. What do you think of this lesion? Acute intracerebral hematoma on the right side. Then what do you think of this? Yes, area of encephalomalacia or chronic infarction on the left side. Okay, what do you think of this? Yes, right frontal epidural, right. This is the right frontal epidural hematoma. And what do you think of this? Very good. This is the subarachnoid hemorrhage. And what do you think of this structure? Left frontal lobe. And this area? Left temporal lobe. And this artery? The basilar artery. And here? The bones. And here? The vermis of the cerebellum. And what do you think of this? Right subarachnoid hemorrhage. This is the right side and this is the left side. Left subarachnoid hemorrhage and right epidural hematoma. Very good. The association is usually post-traumatic. What do you think of this? Infarction on the left and infarction on the right. This is acute and this is also acute. Very good. Then what do you think of this? Infarction on the right. Acute, subacute, chronic. Okay, if it is subacute, this ventricle should be similar to this ventricle. What do you think? Yes, it's compressed. This ventricle is relatively compressed. Then you are dealing with an acute infarction, and you can see hyperdensities inside the infarction itself, representing hemorrhage. And this is hemorrhagic infarction. And I thank you very much.